topic on prognostic factors in head and neck cancers. So first of all, some introduction. Likewise, treatment of head and neck cancers require an accurate risk stratification in order to determine the type and extent of therapy and the expected clinical outcome, where we do the physical examination, diagnostic imaging studies, and pathological review to enable the clinician to determine what is the size and extent, what is the status of lymph nodes, and what is the likelihood of metastatic disease. Thus, then we generate an accurate TNM staging for each of the patient. So the prognostic factors are first of all divided into basically these 5 parts. That is the factors related to the primary tumor, factors related to the cervical lymph nodes, then the factors related to the patient's demographics, then the factors related to the patient's general medical condition, and finally the molecular prognostic factors. So we will discuss them one by one. First of all, factors related to the primary tumor. In this, first thing is the tumor dimensions. We know T stage is determined clinically by measuring the maximal surface diameter of the mucosal neoplasm, or pathologically by measuring the maximal cross-sectional diameter of the resected tumor. T stage is considered a very important risk factor so as to present with the concomitant nodal metastasis, local recurrences, and poor survival. So there is one paper by the Murray et al. Showing the evaluation of size in prognosis of oral cancers, in which they have presented about the greatest surface diameter of the cancer together with the suspicious of the regional nodal metastasis that forms the basis for the prognosis through the clinical TNM staging. However, in this study, basically the conclusion was that the greatest surface diameter of the oral cancer, when greater than 2 centimeter, it is an unreliable predictor of tumor behavior. So it's a small pilot study that suggests that tumor thickness may be the better predictor comparing to the size. Then another factor is the margin status. We know it is the single most important surgeon modifiable factor. The margins, as per some other guidelines, like in UK guidelines, they have defined it a negative margin of an invasive tumor more than 5 mm away from the surgical margins, close margins when it is within 1 to 5 mm from the surgical margins, and positive means when it is less than 1 mm from the surgical margins. So there is one meta-analytical study by the Anderson et al. That shows the margin size and local recurrences in oral squamous cell carcinoma. It was basically the Medline and Embase search studies that look at the local recurrence rate following the excision of the primary SCC without any adjuvant therapy. So in this, they define key close margins less than 5 mm and the margins involved, that is 1 mm, are the key indicators for adjuvant therapy. In this, the aim was to assess the impact of pathological margin size on the local recurrence rate. And in this study, they find out that recurrence rate was pooled to be 21% absolute reduction when margins are cleared more than 5 mm. There are some other studies likewise that shows about the definition of the margin status and what is up to what part the loco-regional recurrence can occur and what would be the survival ratio. Like the Chen et al. Study in 1987 that had a total number of patients of 270 representing the margins of 5 mm and showed the loco-regional recurrence, whether inadequate or adequate, with survival benefit that is up to the 5-year disease-free survival rate that they have shown. Similarly, there is a Lorey and Strong et al. Study in 1990, then McMahon et al. Study, then various other studies likewise that have shown that margin status associated with loco-regional recurrence and disease-free survival rate, and various other multivariate analytical studies that shows that how much there can be the improvement with The definition of surgical margins 5 mm or more than 5 mm. So tumor differentiation was firstly classified. There was a borders classification that has defined it as a on the basis of histological grading, whether it is a grade 1 well differentiated, in which the number of undifferentiated cells were less than 25%, then grade 2 moderately differentiated when the undifferentiated cells are less than 50%, poorly differentiated grade 3 when they are less than 75%, and finally anaplastic or pleomorphic grade 4 more than 75% undifferentiated cells. Then in 1992 there came another classification, that is the Bryan's classification, in which they have classified the invading cell grading system into the basically the 5 parts, that is the degree of keratinization, nuclear polymorphism, number of mitosis, pattern of invasion, and the lymphoplasmacytic infiltration. And they have given the scourge based on these parts, like 1, 2, 3, 4, based on that part. Then another important factor is pattern of invasion. We knew that infiltration of perineural spaces occurs in up to 52% of head and neck cancers, and it was first noticed by the Ballantini et al. In 1963. So what is perineural invasion? It is the process of involvement of small, microscopically identified, unnamed peripheral nerves in the immediate vicinity of the invasive neoplasm, and it occurs when the tumor cells assess the perineural space, aided by the complex interplay between the tumor cell factors and the local nerves. Further, perineural invasion can be subcategorized as intratumoral, peripheral, and extratumoral, or classified as focal versus multifocal. Then there is a perineural invasion, and then there is a perineural spread. Perineural spread means when there is involvement of typically named central nerves, whereas perineural invasion means when there is an involvement of unnamed peripheral nerves. So this is the difference between the two things. Now, how to define clinically the involvement of perineural invasion? Like the symptoms of dysphagia secondary to involvement of vagal trunk, or pain and paresthesias along the territories of glossopharyngeal or trigeminal nerves. Radiologically, it's a obliteration of fat within the pterygopalatine fossa, or enlargement of neural foramina, or increased enhancement in the region of Meckel's cave. Pathologically, it is mediated by the presence of NCAM, that is nerve cell adhesion molecules, on the surface of squamous carcinoma cells, which engages in the homophilic binding with these receptors expressed in the neural and perineural tissues. So perineural invasion is typically the process of these microscopically involved peripheral nerves, and which basically involves all the unnamed peripheral nerves. So there is one study by the Nair et al. That shows that perineural invasion is an independent prognostic factor in oral cancers that warranties the adjuvant treatment. So this was basically the retrospective study of around 1,524 patients that analysis has performed to show that perineural invasion was 20.3% and higher in the tongue cancers, with how that perineural invasion can affect the disease-free survival rate and overall survival rate. So basically the aggressive treatment of the primary cancers will require coincidentally the neck dissection also, specifically if there is an involvement of perineural invasion, because PNI will worsen the survival ratio and will prompt towards the treatment for adjuvant treatment. So presence of PNI should be very much carefully evaluated and documented in every surgical specimen with SCC of oral cavity, because it has a significant prognostic value. And aggressive treatment of primary cancer by adding the adjuvant RT with neck dissection is important if they are PNI positive. So basically, they have also shown that tongue cancers have a higher incidence of perineural invasion, and perineural invasion should be considered as a marker that signifies aggressive biological and metastatic behavior. Then there is another factor, that is the depth of invasion. Likewise, Spiro and colleagues in the mid 1980s have find out the prognosis of oral cancers worsens as the tumor grows thicker. So there is one meta-analytical study by Caldieri et al. In which they have shown the depth of invasion is a very good prognostic indicator for early stage oral SCCs, where they have shown that recurrence rate or the lower chances of survival if there is a high tumor depth of invasion present. So according to the definition, what is the depth of invasion or tumor thickness and how it should be accurately measured? So basically it is measured from the basement membrane of the closest adjacent normal mucosa to the deepest point of the tumor invasion, and greatest depth of invasion is measured by dropping a plumb line from the horizon. Tumor thickness more than depth of invasion if the tumor is exophytic, and less than depth of invasion if the tumor is endophytic. Then there is another study by our own surgeon, Dr. Kunal Ranjan sir, that have shown that interrelation among the triad of depth of invasion, perineural invasion, and tumor size in SCC of tongue and floor of mouth. So basically, they have shown that the triad of these three factors is very much interrelated and very much significant for cervical nodal metastasis, recurrence of the disease, and overall survival. Now the thing is, positive perineural invasion is an independent factor predicting the poor prognosis irrespective of size of the tumor or level of depth of invasion, whether it is less than or greater than 1 centimeter. So therefore it becomes imperative to establish specifically on the deep margin clearance along with the dissection of the lymphofatty tissues in the floor of mouth involvement. So this was a study of SCC tongue in which total 108 patients were studied with involvement of 59 patients having CA tongue and 20 patients having the involvement of floor of mouth, and another 29 patients having involvement of both tongue and floor of mouth. Out of these, 71 underwent surgery, and the results showed that perineural invasion was seen in 15 cases in early T1, T2 lesions where the depth of invasion was less than 1 centimeter, and in 28 cases the advanced cancers, that is T3, T4, where the DOI was more than 1 centimeter. So the skip metastasis was around 61.9% overall. So it clearly shows that the triad is responsible for cervical lymph node metastasis and prognosis. Then we have another factor of lymphovascular emboli, which is defined as a tumor embolism within the space in which the tumor cells invade the vascular wall or in which endothelial cells are arranged. It has a low incidence in oral squamous cell cancers, and mostly it is associated with other factors. As such, I did not get very much studies about how the important factor can be the lymphovascular emboli. Most of the time it is associated with other factors only. Then another factor is the pattern of invasion, where we divide it into the 5 parts according to the shape of involvement of tumor. Type 1 is the tumor invasion as shown in the diagram. Also, it is the broad pushing manner. Then type 2 means invading like finger-like solid cords and strands. Then type 3, where they are showing some invasive islands of tumor with more than 15 cells cluster. Then type 4, when the islands representing are less than 15 cells of the cluster. And finally type 5, where the tumor islands are more than 1 mm away from the progressive end of the tumor. So there was one study by Mishra et al. Sir, which represents the worst pattern of invasion in SCCs, oral SCCs, and how the worst pattern of invasion is an independent prognostic factors. So in this, we clearly sees in this Kaplan-Meier curve the disease-free survival rate, and how much the disease-free survival rate is better when it is involvement is when it is a type 1 to 3 worst pattern of invasion, comparing then type 4, which has a lesser disease-free survival rate, and type 5 has the worst disease-free survival rate. So after the after this covering of the factors related to the tumor, there come another factors related to the cervical lymph nodes. The first factor is the nodal size. So the nodal size means the diameter of the largest metastatic cervical lymph node, contributing to the assessment of end stage in head and neck cancers and how it corresponds with the total tumor burden. Although studies have not found any independent relationship between the pathologically assessed nodal size and survival when other variables are considered, but the diameter of the largest positive cervical lymph node may serve as a helpful clinical predictor of outcome, but not as an independent prognostic factor. So this is one study by the Snow et al. Showing the prognostic factors of neck node metastasis. It was a retrospective study which was carried out in 405 patients, where they did radical neck dissection, and the factors such as extranodal spread and histologically positive nodes have been shown to be much more prognostic importance than other clinical parameters. Then another parameter is the number of positive lymph nodes and the site. The number, size, and location of positive cervical lymph nodes define the end stage, and it provides a very important information regarding the prognosis. So in multivariate analysis, which is involved by the tumor site and the patient age, number of positive nodes is very much significant and an independent predictor for survival. So there was one study by Memele et al. Showing the lymph node prognostic factors in head and neck cancers. Again, a retrospective study which was carried out in various parts of the head and neck cancer, head and neck tumors parts, and they showed that the clinically positive nodes, if the size is more than 3 centimeter, in which the radical neck dissection was performed, so it basically shows that survival model is adjusted on the primary tumor cells, basically on the basis of the size of the node, as well as other factors like extracapsular spread and the number of positive nodes. So the two most important prognostic factors are, one is the number of positive nodes and another is the extranodal extension that showed the survival ratio benefit. So this was one chart that shows about the predictor of the distant metastasis and 5-year overall survival rate in the study of 914 patients, and it clear-cut shows how the number of positive cervical nodes is a good indicator specifically for the outcome of distant metastasis and 5-year survival rate.
Number of positive cervical nodes is a good indicator for survival outcome. As in, which means?
No, sir. Basically it indicates, sir, how the distant metastasis can be. More the number of nodes are involved means there are more chances of distant metastasis, and lesser is the 5-year overall survival rate.
Oh. So basically, this chart shows that even a single lymph node can lead to decrease in survival by almost up to 50%.
Yes.
Yes. जैसे तुमने वो नहीं शो किया है, कौन सा लाइन किस चीज को इंडिकेट कर रहा है? ये मैमेल एट ऑल का पेपर है ना, उसका ही है ना ये
सर मैमेल एट ऑल का पेपर है सर, ये उसमें. Then the another factor is the extracapsular extension. Mostly extracapsular extension occurs in roughly 60% of the patients with positive cervical nodes, and it is a very much important factor in predicting the patient outcome. Further, it can be divided into the following 3 levels based on the morphology. that is a macroscopic extracapsular spread with involvement of adjacent structures such as IJV or over the skeletal muscles. Then second, if the macroscopic extracapsular spread confined to perinodal fibroadipose tissue only. And third, if it is a microscopic extracapsular spread. So there was one study by the Nicolai et al. That shows the prognostic determinants in supraglottic carcinoma about these various univariate and the Cox regression analysis. It was a case series of 281 patients affected by the supraglottic cancer, whether treated with surgery only or surgery followed by RT. The results basically shows the survival listed in the order of higher relative risk of death, that is extracapsular spread, then involvement of medial wall of piriform sinus, thyroid cartilage invasion, metachronous tumor, anesthesiologic risk according to American Society. So in this study, the basic conclusion was that extracapsular spread is the most important factor, prognostic factor with supraglottic carcinoma, which clear-cut indicate the predictor for the poor disease-free, cause-specific and overall survival rate. And how this in this study they have shown that patients with N0 experience a 5-year survival rate of 65%, which is compared to 49% if it is nodal positive without extracapsular extension, and 20% if it is nodal positive with extracapsular extension. Then there is another study by the Lehman et al. That showed that regional lymph node involvement and the significance in the development of distant metastases in head and neck cancers. In this, again, they have shown that the presence of extranodal spread has a threshold increase, three times threshold increase in incidence of distant metastasis compared to without extranodal extension. Then there is another Bernier-Cooper trial that defined the risk level in locally advanced head and neck cancers. So basically it was a comparative analysis of giving concurrent postoperative radiation plus chemotherapy trial. In this trial, they basically have shown that extracapsular extension and the microscopically involved surgical margins, these were the only two risk factors for which the impact of chemo plus radiation was significant. So the conclusion was that microscopically involved resection margin and extracapsular spread from the neck nodes are the two most important prognostic factors for the poor outcome. Then there came another prognostic factors relating to the demographic parameters. First demographic parameter is age. Age is commonly considered a covariate and is known to influence the outcome in certain types of cancer. Head and neck cancers arising in the patients at either extreme of the age continuum may result from different etiological agents and manifest with the different clinical outcomes. So there was one study that shows that how the treatment outcome occurs in the young patients with SCC of head and neck. In this, they have shown that overall survival, cause-specific survival and relapse-free survival between the young patients with head and neck cancers and old patients, that is age more than 40 years of age. So basically it was a comparative study, and in this study they have found out that 5-year cause-specific survival in both the groups was not statistically different. Young patients may have a significant better 5-year overall survival compared to older patient group, but overall cause-specific survival was not very much specifically significant. Then another factor is sex. Generally, it is not considered as significant determinant of survival. but indeed most of the large studies, it has failed to find any significant difference in outcome with respect to sex. So there was one paper by Kowalski et al. That showed the prognostic factors in the laryngeal cancer. The patients were submitted for the surgical treatment, and in this again we studied about the disease-free survival and the overall survival for the laryngeal cancer patients. And the other additional factors, they were closely associated with disease-free interval, that is age, site of the primary tumor, whether transglottic, glottic or supraglottic, extracapsular spread, then metastasis, then surgical margins, then type of paratracheal node dissection, and prior tracheostomy. Out of all these, except for extracapsular spread, the same factor related to DFI was significantly related to overall survival, whereas other factors like race, sex, end stage, vascular embolization, and histological grading, they were independent predictors for risk of death. Then another parameter is alcohol and tobacco exposure. Now, exposure to these carcinogens result in specific molecular insults that promote the neoplasia. For example, cigarette smoking has been associated with overexpression of proto-oncogene BCL2, which leads to inhibit apoptosis. And addition of alcohol with tobacco has been associated with non-specific mutation in p53 tumor suppressor gene. So there was one study by Day et al. That showed that second cancers following oral and pharyngeal cancers, what is the role of tobacco and alcohol? In this study, they evaluated the relationship of smoking and alcohol consumption to the development of the second cancers group. Now, the results were that tobacco smoking and alcohol drinking contribute to the risk of second cancers, with the effect of smoking more pronounced than the alcohol. And it also shows specifically that among the drinkers, second cancer risk was more for the beer intake than other types of alcohol, with the odds ratio of for second aerodigestive tract around 3.8. It also shows that there was no reduction in risk if there is a cessation of smoking or drinking after or during the diagnosis. So basically, it concluded that oral and pharyngeal cancers with the highest intakes of tobacco and alcohol are the ones more prone to develop second primary cancers. Then there are the factors related to the patient's general medical condition. First is the comorbidities. Now, first of all, Piccirillo has classified the 4-tiered classification for these comorbidities, that is none, mild, moderate, and severe. And for example, the moderate comorbidity means poorly controlled hypertension, old stroke, or history of alcoholic seizure, whereas severe comorbidity include congestive heart failure or myocardial infarction within the last 6 months with recent stroke and severely decompensated alcoholism. So there was one paper on Piccirillo et al. That showed how these prognostic factors of comorbidities in hospital-based cancer registry are important for being a prognostic factors. So in this, basically the result was that severity of comorbidity strongly influenced the survival in a dose-dependent fashion, and the impact of comorbidities was independent of cancer staging. So comorbidity is an important independent prognostic factor that they have shown. Another factor is the nutritional status. What is the impact of nutritional status on the prognosis of the patients with head and neck cancers? The thing is that relationship between the nutritional status, post-operative complications, and survival has been explored in several prospective studies. In analysis of these various different nutritional parameters, the main parameter was like 10% weight loss in the 6 months preceding the surgery. It was the only significant and independent predictor of the the major post-operative complications. So there is one study by the Marian et al. That shows that how malnutrition, which is recognized as a poor prognostic indicator for cancer treatment related morbidity and mortality, and overall and disease-free survival rate was performed in this study for the follow-up up to the 3 years. The three things, that is a combination of male gender, pre-operative weight loss, and major post-operative complications. These three factors were related to the early death. The conclusion was that pre-operative weight loss and major post-operative complications have a negative effect on the survival undergoing the surgery. Then another factor is anemia. Anemia commonly occurs in patients with head and neck cancers due to various number of causes, including some comorbid illness, intraoperatively blood loss, toxicity from the chemotherapy or radiation, or malignancy associated anemia of chronic disease. It commonly thought to enhance the radio resistance by enhancing tumor hypoxia. Now, as such, there is no clear-cut demarcation how much the range of HB is minimal required, but usually it is 10 to 14 between them, but it depends from various studies, study to study. So there was one paper by the Lee et al. That shows that how anemia is associated with decreased survival and increased locoregional failure in patients with locally advanced head and neck cancers. In this study, basically it was the study in which they have shown that patients with advanced tumor, that is stage 3 and 4 cancers of head and neck, along with the surgery with giving chemotherapy or conventional radiation therapy. So the estimated survival rate was 35.7% at 5 years, with normal high versus 21.7% in anemic patients. So it shows that how the survival rate was impacted when the patient is anemic. And it also shows that locoregional failure, which was 51.6% at 5 years with patients versus 67.8% in anemic patients. So it clear cut shows that the survival rate is impacted with high rate chances of locoregional failure if the patient is anemic. Then there came another molecular prognostic factors. First one is the P53. Now, what is P53? It is a transcription factor with tumor suppressor function that negatively regulates the cell cycle and serves to protect the integrity of the genome. It resides on chromosome 17p13 and composed of 11 exons. The loss of P53 function may contribute to tumor aggressiveness by promoting the resistance to radiation and chemotherapy, accelerated growth in hypoxic conditions, and tumor neovascularization. There are two variants of P53. One is the wild type variant, or one is another is the mutant line P53 variant. So when compared to the cells with the wild type P53 mutant cell exhibit more resistance to ionizing radiations and chemotherapeutic agents. So there was one paper by Koch et al. That shows that how P53 mutation and the locoregional treatment failure in head and neck cancers are related to each other. In this study, they have shown that there is a direct sequence analysis which has been demonstrated with alteration of the gene, which is occurring in approximately 45% patients of head and neck cancers, and the control of locoregional disease and overall survival following the radiation therapy, how the implications of P53 mutation is related to these factors. So in this study, they have shown that mutation of P53 gene, it was not associated with patient's age, sex, or tumor, or stage, or any primary tumor site, or any regional lymph node status. The conclusion was that mutation of P53 gene is associated with increased risk of locoregional failure in the patients with invasive head and neck cancers, which needs to be treated with adjuvant RT. Then there is another factor, that is angiogenesis related markers. Now, angiogenesis means sprouting of new blood vessels from the pre-existing endothelium, which enables the growth of the tumor beyond the microscopic size. So there is one factor, vascular endothelial growth factor. It is a dimer composed of two identical disulfide linked subunits arising from the different splicing of a single gene, and how it frequently expressed in head and neck cancers. Expression of both vasculoendothelial growth factor and platelet derived this epithelial growth factor, endothelial growth factor, has been reported to correlate with the microvessel density in head and neck cancers. An elevated tumor microvessel density, which is assessed with the IHC, has shown to be correlated with the risk of cervical lymph node metastasis in oral and nasopharyngeal cancers. So this was one study by Fukawa et al. That shows the expression of thymidine phosphorylase and vascular endothelial growth factors in head and neck cancers. In this study, they basically suggest that how vascular endothelial growth factor is involved in angiogenesis in head and neck cancers, and how it impacts the tumor growth with more chances of risk of failure. Then there is another factor, that is cyclin D1, which is also known as PRAD1. It is a proto-oncogene located on chromosome 11q 13289. It serves as a rate-limiting controller of G1 phase progression. Cyclin D1 is the most commonly amplified oncogene in head and neck cancer, with approximately 35% of tumors revealing the increased gene copy number with the fluorescent in situ hybridization analysis. Now, the overexpression of cyclin D1 shortens the G1 interval and it reduces the cell's dependence on mitogens. So there was one Mikolidis study, Mikolidis et al., that shows the overexpression of cyclin D1, how it indicates a poor prognosis in SCCs of head and neck. So in this study, they shows that overexpression of cyclin D1 in the patients with SCC, it was not associated with the known prognostic factors like any tumor or nodal stages, and the difference was statistically significant in a stepwise proportional hazardous and regression analysis. The overexpression was found in 42% of the patients, and it was very much important as a prognostic significance in head and neck cancers. Then another expression is EGFR and TGF alpha. Now in head and neck cancers, autocrine activation of EGFR by TGF, it promotes the cellular proliferation and inhibits the apoptosis. So there was one Chung et al. Study which uses the FISH technique in 75 patients with stage 1 to 4 to determine the patients with more than 2 copies per cell of the EGFR experience a high risk of progression and death. Thus, the cumulative evidence suggests that EGFR protein overexpression or gene amplification associated with poor prognosis. Then another factor is the human papilloma virus. Now, HPV is a small circular DNA that infects the basal cells in the squamous epithelium. It is mainly transmitted through sexual contact, and recently there is a rise with oral sexual practices. Mainly HPV causes cancers by the means of viral oncoproteins E6 and E7 that inactivates tumor suppressor genes P53 and RB, retinoblastoma. HPV associated cancers are typically occur more with younger age group, more with the white, non-smokers, non-alcoholic abusers, with higher socioeconomic status with primary tumors, and it occurs more commonly in oropharynx. So this is one study of Ang et al. That shows that human papilloma virus and survival of the patients with oropharyngeal cancer. In this, the 3-year overall survival rate was similar. and it shows that tumor HPV status is strongly an independent prognostic factor for survival among the patients with oropharyngeal cancers. So basically the summary is to understand the vast array of all these prognostic factors that contribute to the prognosis of the patients with head and neck, enables an accurate assessment of the patient's risk, and it promotes the development of optimal treatment strategies. Thank you, sir.
So I think you have put in good effort, a lot of effort to make this presentation. It's a really good presentation. We have covered all the topics thoroughly. One thing, so you have pretty much said everything which is required. What I just wanted to give a comprehensive message and summarize about it is, let's see, we have to understand there are two things. One is prognostic factors, and the other thing is stratification, right?
Yes.
So we have to understand that what are the poor prognostic factors and how we can use these prognostic factors to stratify the patient into one or the other risk category, right?
Yes.
So can you name any risk stratification strategy for the patients which we use, which visit in our OPD? Which is the most commonly used risk stratification strategy? Anyone? Dr. Survi?
Sir.
Dr. Shikha? Dr. Vijay?
Sir, margins मतलब question clear नहीं मतलब.
No. Suppose a patient comes to your OPD, okay? So what is the initial risk stratification which you use to prognosticate the patient?
Sir, usually we do high risk and low risk, usually in most of the cancers.
So how do you say high risk and low risk? What are the criteria?
Or we can say which is the more definitive or more evidence based, where it's clear cut. And that
give the name of the most commonly used risk stratification which we use in our clinic. Someone said that. Someone said it? TNM staging. Very good. So understand, TNM staging is a risk stratification, while T stage, N stage, and M stage, they are the prognostic factors, right?
Yes.
So and Rizul, is there any other
grade usually, or the tumor differentiation, sir?
And any other molecular marker, Rizul, which nowadays like we are also using? Common, particularly in your HPV patient.
P16, sir.
Yeah,
P16. Okay.
Yes. Hello, Rizul.
Yes, sir. Yes, sir.
As I joined late, like, have you talked about, like, I heard that you have, like, you talked about P53 and
yes,
most
sir.
everything, like tobacco, alcohol.
Yes, sir. Yes.
So any other recent risk prognostic factor which is under research, which is mainly used in your CA stomach nowadays?
Don't know, sir.
Lymph node ratio, sir.
Did you discuss about neutrophil lymphocytic ratio?
No, sir. No, sir.
Just read about it. It is a recent development that
Okay,
your neutrophil to lymphocyte ratio. It has also got some prognostic indication and importance in head and neck cancer. Generally, people say that if your neutrophil to lymphocyte ratio is more than 5, then it bears a poor prognosis, because it because it is an indicator of your tumor-related inflammation in the body. So, not level 1 evidence still so far, but some studies are going on. So, just read about it.
Okay, sir.
Great. So, basically, now we get an idea that what are the prognostic factors and what is risk stratification, right? So you'll see that TNM is one of the most convenient method of risk stratification using some prognostic factors which are tumor, node, and metastasis, right? And since the studies have shown that in nodal metastasis, the extranodal extension is one of the most important factor in this important prognostic factor. Similarly, for tumor, depth of invasion is a very important prognostic factor, which are basically pre-treatment prognostic factors. So they have been taken into account in our TNM stage. Clear?
Yes.
Now, as Dr. Kunal was saying, that for oropharyngeal malignancies, we came to know eventually that HPV positivity is a very important tumor, important prognostic factor, to the account that it can totally change the prognostic outcome, totally change the survival outcome of the patient. Hence, what AJCC did, that they incorporated P16, which is a surrogate marker for HPV, as a prognostic factor and for stratification, right? So if it is P16 positive, it becomes HPV positive and its prognosis changes. If it is P16 negative, it becomes HPV negative and its prognosis changes. So again, there is a different bifurcation stratification, right?
Sir. Yes, sir.
Okay. So these are pre-treatment prognostic factors. Then comes post-treatment. Post-treatment, what does post-treatment mean? When you have operated the patient, then you would like to do an in-depth analysis and see what are the factors which can affect the prognosis of the patient. And if there are some poor prognostic factors, we can take help of these prognostic factors and decide the treatment line of the patient. Okay? Whether what adjuvant treatment and radiation or chemotherapy is to be given to the patient, right?
Yes, sir.
So there are soft indicators and hard indicators for chemotherapy. Clear?
Sir.
What are the hard indicators? Positive margin or extranodal extension. These are hard indicators. What are the soft indicators for chemotherapy? Multiple nodal positivity. You have 10 nodes positive. I will err towards chemotherapy. Okay?
Sir.
You have very low neck nodes. Many people will err towards chemotherapy. Nothing wrong with that. Okay? We have many evidence. We have NCDB data analysis. We have multiple papers by different authors which identify these as poor prognostic factors, right?
Yes.
Now, after that, apart from chemotherapy, if we do not have hard factors for chemotherapy, we then try to see, are there any hard indicators for radiation? So suppose a patient is T3 or T4. So this is a hard indicator for adjuvant radiation. Why? Because it is a very poor prognostic factor. So suppose there is a patient which is T2 and depth of invasion 9 mm or 10 mm. So this tumor is largely bordering towards T3. Had there been 1 mm more of invasion, you will go towards T3. So these are soft indicators for adjuvant radiation. So these can be contended. Some might say that I will err towards radiation. Some might say that I will not err towards radiation. So what I am trying to tell here is the perspective about understanding about the prognostic factors and risk stratification and how we use our knowledge of prognostic factors to decide our treatment line. Right? These are the most important thing that you have to understand in oncology is prognostic factors, because these are the things which help you in deciding your treatment plan. Getting my point?
Yes.
Great. Anything else, Dr. Guna? Dr. Vinay?
I think we have done a great presentation.
Great
So much
presentation,
improvement.
I must say. I was about to cry.
Thank you, sir.
Presentation. Okay.
Sir, nutritional assessment, is there any score, sir?
So I'm not aware of the score which we use, but there are multiple different scores which are used for assessment. And you can find that in your textbook. We are not using it routinely in our clinics, but that is a very important factor which we can use. So see, nutrition is a very important factor. So you have to understand that the moment the patient enters into your clinic, okay, you have to assess the patient psychologically, nutritionally, physically, and you have to tell the patient in a very graded manner that what problems he is facing and what is going to be the treatment line. All of this is called as prehabilitation. What is it called? Prehabilitation. So you will see, just as he said, anemia is a prognostic factor, right? You will see for larynx CA, protein has been identified as a prognostic factor for leak. So we know that nutrition has a role in determining the prognosis of the patient, right? A patient which is very poor nutritionally built, but what score we are using, I'm not aware of it. I can read about it and let you know.
Okay, sir. Thank you, sir.
Thank you.
Thank you, sir.
Okay, Rajat, thank you.